Hello, everyone, and welcome to today's edition of Pathcast. Today is October 7th, 2025. I'm Rifat Mannan in California. And today we are here to welcome Dr. Keir, who works at Texas Children's Hospital, where she is Assistant Professor of Pathology and Immunology at Baylor College of Medicine, Houston. And today she is going to give a talk on a very important topic, and which is a day-to-day practice for many of the general pathologists all over, is placental inflammation and infection. And her title is Pathology Perspectives in Perinatal Medicine. And we are really honored to have Dr. Keir with us today. Thank you so much for joining us. So over to you now. Thank you.
Thank you very much for the introduction. I'm just going to turn my video off whilst I do the talk, and I can turn it back on at the end. So in this session, I'm going to discuss placental inflammation and infection through the lens of pathology, focusing on the key histological patterns that we encounter, the mechanisms that drive them, and their clinical significance. I plan to move between acute and chronic inflammatory processes, examining how the microscopic findings can provide insight into pregnancy outcomes and also recurrence risks. And hopefully by the end of this talk, the goal is to deepen our understanding of placental inflammatory lesions to help distinguish acute from chronic processes, both morphologically and mechanistically, and also to appreciate how these patterns can relate to clinical presentation and prognosis. So I'd just like to begin by setting the stage with a brief roadmap of where we're heading in the presentation. So I'll start with a short refresher on what normal placental anatomy and histology looks like, just to set the stage. And then from there, I'll address some of the more common acute and chronic placental lesions, as I mentioned, including kind of potential clinical impact and recurrence risks where available. And then finally, I plan to touch upon some emerging or future research priorities that may help to reshape the current landscape. But first, before getting into the specifics of placental inflammation and infection, I think it's important to really start by framing why placental pathology matters and why it deserves, or at least I feel it deserves, this level of focus within perinatal medicine. So the placenta is far more than just a passive interface. It's a dynamic immune organ that must balance maternal tolerance with defense against infection. And personally, I think the placenta is amazing in that it's the only naturally occurring organ that always forms at the interface of two living, genetically distinct individuals, and therefore constantly has to negotiate that fine immunologic balance. And this dual role explains why inflammation, whether it's infectious or immune-mediated, can have profound implications for both the mother and the fetus. So the placenta is essentially the diary of a pregnancy. It records everything that happens in utero. And when we examine it, we're not just reviewing tissue, we're reading the story of that pregnancy. And inflammatory lesions can be among some of the more informative, helping us explain cases of preterm birth, fetal growth restriction, or stillbirth in some cases. So recognizing these acute processes accurately is vital for helping to guide clinical care and for understanding the pathophysiology of adverse pregnancy outcomes. I think placental pathology matters because it's a cornerstone for understanding, diagnosing, and managing pregnancy complications. And its integration into clinical care and research is definitely increasingly becoming recognised as essential for the advancement of maternal fetal medicine. So touching upon the normal kind of placental structure and function, I think it's useful to revisit the normal structure. I'm sure some of you may well have seen this classic diagram before, but briefly, a successful pregnancy ultimately depends on how well the placenta functions. As I said, it's the vital organ that connects the mother and the baby, but keeping their two circulations separate whilst allowing oxygen, nutrient and waste exchange to take place. On the maternal side, the blood flows from the endometrial arteries into the intervillous space where it bathes the chorionic villi. And this is where most of the exchange occurs, before then draining back through the endometrial veins. On the fetal side, deoxygenated blood will travel through the umbilical arteries, branching through the chorionic plate and into the villus tree. And I kind of imagine it as a tree with the umbilical cord as the trunk, the stem villi kind of as the big branches, and then the terminal villi as the leaves of the tree. And it's at this leaf level, particularly across the vasculo-syncytial membrane, that maternal and fetal exchange truly happens. Oxygenated blood will then return to the baby via the umbilical vein. So structurally, the chorionic plate is what forms the fetal surface. The decidua basalis is the maternal side, and the chorioamniotic membranes create the sac that surrounds the fetus. You have anchoring villi that secure the placenta to the maternal decidua, and then placental septa, which extend into the intervillous space and help stabilize and organize the architecture. So together, these features create a remarkably efficient and low resistance system that maximizes exchange, but whilst also maintaining, under normal circumstances, complete separation of the maternal and fetal blood. This slide just briefly pulls together the main features of gross and microscopic anatomy of the normal placenta, essentially kind of setting the foundation for what follows in the talk. In regards to the placenta when received fresh, as seen in the top left and top middle images, on the fetal side you can see that the smooth glistening surface is covered by a translucent amnion. The umbilical vessels radiate out from the cord insertion and branch across the chorionic plate before they dip into the villus tissue below. And normal cord insertion generally is central or just a little off centre. Now, if we flip to the maternal side, the appearance changes. It's dark, red, spongy and lobulated, divided into these cotyledons by the placental septa. And each of those cotyledons represents a distinct unit of maternal circulation. Microscopically, we can start to see how structure underpins function. So in the bottom left, you can see a low power view of the umbilical cord containing the 2 umbilical arteries and 1 umbilical vein. It's all surrounded by the Wharton's jelly, and then the cord itself is covered by amniotic epithelium. In the bottom middle image, you can see that the normal peripheral membranes essentially are formed of 3 layers. You have the amnion on the fetal side, chorion in the middle, and then the decidua on the maternal side. And then the chorionic villi are where the maternal-fetal exchange takes place, and they can be seen in the 2 images on the right, essentially the leaves of the tree. Placental villi contain fetal vessels within a mesenchymal stroma of which also includes kind of Hofbauer cells, and this is encased by cytotrophoblast and an outer multinucleated syncytiotrophoblast, and that interfaces with maternal blood. And that outer syncytiotrophoblast or syncytiotrophoblast membrane, as seen in the bottom left, is that really thin vital membrane separating the 2 circulations that's essential for nutrient and gas exchange. Now, when we talk about placental inflammation, it really falls into 2 main categories. First, acute inflammation, which is typically neutrophilic and most often infectious in origin, has a classic example of chorioamnionitis from ascending bacterial inflammation. Secondly, then there's chronic inflammation, which tends to be dominated by lymphocytes and macrophages. The chronic inflammation usually, although not always, reflects maternal immune activation. and includes conditions such as Villitis of unknown etiology or chronic histiocytic enterocolitis. Recognising which process you're dealing with isn't just a histological exercise. It helps us to infer the timing, in some cases understand the pathogenesis, and anticipate the recurrence risk, all of which can be crucial for diagnostic reporting and clinical counselling. Now, I won't cover every entity in detail today, there simply isn't time. I'll move through these broad two groups, looking at some of the key entities and highlighting them by a couple of case studies along the way. So, although there are some exceptions, infection typically reaches the placenta via two main routes, either ascending infection through the cervix and membranes, which is by far the most common route, or hematogenous spread through maternal blood. The host response depends on the route, so neutrophil recruitment dominates in ascending infection, whereas hematogenous spread often triggers a mononuclear response. Cytokine release, vascular injury, and trophoblast activation are central to both, and are setting off cascades that shape the lesions we see histologically. But once infection reaches the placenta, what happens next? So in acute inflammation, the first responders are the neutrophils. Chemokines and cytokines released by the trophoblasts and the maternal leukocytes drive their recruitment, setting the stage for the acute inflammatory response. Cytokines such as interleukin 8, interleukin 6, and TNF-alpha mediate the establishment of chemokine gradients in response to microbial products and pro-inflammatory cytokines. And the resulting chemotactic gradient directs neutrophils from the maternal or fetal circulation to sites of infection or tissue injury, producing the characteristic neutrophilic infiltration seen in acute chorioamnionitis, for example. Although this response is primarily protective, excessive activation can have deleterious effects, disrupting placental integrity and function, and driving the pathology of acute placental lesions and contributing to complications such as preterm labour, rupture of membranes, and neonatal sepsis. Chronic placental inflammatory lesions, on the other hand, are primarily driven by maternal T-cell mediated immune responses against fetal tissues, with chemokine-driven recruitment and a breakdown of tolerance, resulting in a spectrum of chronic inflammatory lesions that are linked to complications such as fetal growth restriction, recurrent pregnancy loss, and stillbirth. And they often recur in subsequent pregnancies due to persistent maternal immune sensitization. Of note, the CXCL 9, 10, 11, CXCR3 axis has been a major focus of research since it regulates differentiation of naive T cells to T helper 1 cells and leads migration of immune cells to their focal site. So we've now touched upon both ends of the inflammatory spectrum, but I don't think you can give a placental talk without mentioning the Amsterdam consensus criteria. So to interpret these lesions consistently across cases and institutions, we rely on standardized terminology, and that's where the Amsterdam criteria comes in. It provides the consensus framework for defining, classifying and reporting placental lesions. So the consensus criteria, which was published in 2016, introduced a unified framework for classifying placental lesions, organising them into major categories such as vascular malperfusion, fetal and maternal, and inflammation, acute and chronic. And by establishing consistent terminology and diagnostic thresholds, the Amsterdam system has become the international standard for reporting. It helps to enhance reproducibility, strengthens data collection, and also improves the clinical interpretation. Importantly, though, it isn't a comprehensive atlas. It doesn't cover every entity or clinical pathological correlation in any detail, but rather a foundation for uniform evidence-based reporting and collaborative research across centres from which we can build. So that brings me on to my first case, which is a scenario where rapid placental examination provided key information that directly influenced clinical care. I feel like this case can helps to highlight how placental pathology isn't just academic, and there are times when it can have immediate clinical relevance. And a timely diagnosis can clarify the cause of a fetal or neonatal event or guide management in cases. So this case involves a 24-year-old primate who had a cerclage placed for cervical insufficiency that was detected incidentally at her routine anatomy scan. Despite intervention, however, she returned with PV bleeding, followed the next day by spontaneous rupture of membranes. And 2 days after that, she started contracting, requiring removal of the cerclage as it was under tension. And then subsequently, she delivered a live-born infant 2 days later at 22 weeks and 3 days gestation. In view of the clinical history and also documentation at the time of delivery of a foul-smelling odour to the LICA, the placenta was sent to pathology. So we received the placenta fresh. It had an appropriate weight for gestational age. On gross examination, as you can somewhat appreciate here, the membranes and fetal surface were diffusely opaque. They were thickened and yellow discoloured, and there was a marginal insertion of the membranes. They've been trimmed now, so they are no longer on that image. The umbilical cord inserted just paracentrically. It was hypocoiled, only one coil in 10 centimetres, but showed the expected 3 vessels. However, what immediately stood out on examination of the umbilical cord was the diffuse yellow discoloration and the presence of these scattered white-yellow plaques around 1 to 4 millimetres in size that were present on the cord surface. And this appearance is highly suspicious for Candida infection. So given the macroscopic findings, a preliminary report was issued to the neonatal team within approximately 5 hours of delivery. The infant was already on antibiotics given the history. However, antifungal therapy had not been started, so the placental findings had an immediate and clinically important impact. Histology then subsequently confirmed a severe intrauterine infection. There was a maternal inflammatory response with subacute necrotizing chorioamnionitis, as seen in the 2 images on the left, and a fetal inflammatory response showing umbilical vasculitis in all 3 vessels, so inflammation around all 3 vessels of the cord, and also foci of peripheral pneumocystis, which is inflammation located at the radial periphery or external surface of the umbilical cord, as noted by the arrows in the top right image and seen in higher power on the lower right image. And within these areas, PASF positive fungal pseudohyphae and spores were identified, consistent with Candida species. Unfortunately, despite intensive neonatal management, the infant sadly died at 9 days of life. However, this case still powerfully illustrates the value of timely placental examination, especially when gross findings can reveal infections not yet clinically suspected. So, having seen how infection can present so dramatically in practice, I want to take a step back and just look more broadly at acute chorioamnionitis itself, how we define it histologically, how we stage and grade it, and what the diagnosis can mean clinically. Acute chorioamnionitis is one of the most common placental lesions we encounter. It reflects an acute neutrophilic inflammatory response within the membranes and cord and chorionic plate, most often from ascending bacterial infection. It's important in some respects because it captures both the maternal reaction in the chorion and amnion and the fetal response seen as pneumocystis or vasculitis. think it's useful before looking at the histology to review how common this actually is, how it develops, and what organisms are most often involved. Clinical and histologic chorioamnionitis represent overlapping but distinct entities. So clinical chorioamnionitis is generally identified based on elements such as maternal fever, uterine tenderness, and leukocytosis, whereas the histologic form is defined by neutrophilic infiltration in placental tissues identified microscopically. Globally, clinical chorioamnionitis occurs in roughly 4% of deliveries, although this value is variable by population and criteria, while histologic information is much more frequent, seen in over half of spontaneous preterm births and about a quarter to a third of term placentas. The incidence decreases with advancing gestation, and many cases actually are histologic only without any evidence of clinical chorioamnionitis. There often can be a discordance between the clinical and histologic findings. Most cases begin as an ascending infection from the lower genital tract. Once microorganisms breach the membranes, they enter the amniotic cavity, proliferate, and trigger a maternal inflammatory response. Neutrophils then migrate into the membranes and chorionic plate, while the fetal response manifests as phenocytis and vasculitis, so inflammation of the fetal vessels and the Wharton's jelly surrounding them in the umbilical cord, phenocytis. Ureaplasma species are the most consistently identified pathogens, though most infections, about 70%, are polymicrobial, commonly involving organisms such as E. coli, group B strep, and some anaerobes. Less frequent but clinically significant contributors include pathogens such as Staph aureus and Candida species. Importantly, a subset of cases are sterile, showing a robust inflammation without detectable organisms, where it's considered that the placenta is responding to injury rather than infection, but has the same overall or ultimate outcomes. The macroscopic findings in acute chorioamnionitis can be quite characteristic and often can provide the first clue to an underlying infectious process. Inflammation of the membranes produces a characteristic cloudy, opaque yellow discoloration of both the chorionic plate and the free membranes, reflecting the accumulation of inflammatory exudate. With regards to fetal inflammatory response, when it's prominent, especially in cases of necrotizing phenocytis, the umbilical cord may also appear yellow tinged and can have these pale halos around the vessels, marking areas of intense inflammation. Together, these gross findings can provide a striking visual counterpart to the maternal and the fetal inflammatory processes that ultimately define acute chorioamnionitis. Microscopically, we can appreciate how those changes translate into the characteristic histologic patterns of acute chorioamnionitis, reflecting both maternal and fetal inflammatory responses. So the maternal inflammatory response is staged based on the depth and location of neutrophil infiltration, with stage 1 having neutrophils present in the chorion, chorionitis. Stage 2, the involvement extends to the amnion with amnionitis. And then in stage 3, the inflammation disrupts the amniotic epithelium, which is associated with more intense and clinically significant inflammation. With regards to fetal inflammatory response, that's staged separately, with stage 1 corresponding to umbilical vein phlebitis, so neutrophilic infiltration of the vein wall. Stage 2 is characterized by involvement of one or both umbilical arteries, so when you've got the presence of arteritis. And then finally, in stage 3, there is extension of the inflammation into the Wharton's jelly surrounding the vessels, indicating advanced fetal involvement, and that's what we refer to as phenocytis. As well as the staging, both maternal and fetal responses are graded as 1 or 2 based on the severity, the density and the extent of the inflammatory infiltrate. So grade 1 generally indicates mild to moderate inflammation, whilst grade 2 reflects severe, confluent or necrotizing inflammation. But understanding the staging of and grading of maternal and fetal inflammation isn't just about morphology. It does have some direct clinical impact. These patterns can correlate quite closely with outcomes for both mother and baby. Acute chorioamnionitis or intraamniotic infection significantly increases maternal and neonatal morbidity. For the neonate, complications can include things like sepsis, pneumonia, meningitis, and in severe cases, death. In preterm infants, longer-term effects such as bronchopulmonary dysplasia and cerebral palsy are more common, although obviously there isn't always a direct one-for-one causal relationship. These cases generally are multifactorial, and you've got the complications of prematurity as well as the issues caused by infection, which leads to a more complex overall picture. For a mother, infection raises the risk of dysfunctional labour, uterine atony, or postpartum hemorrhage, sometimes endometritis, or peritonitis and sepsis. Recent studies even have shown a 3.4-fold increase in neonatal and a 2.4-fold increase in maternal adverse outcomes, including term pregnancies, so not just in the preterm cohort. ACOG emphasises rapid recognition, the use of early intrapartum antibiotics, and timely neonatal team involvement to aim to reduce morbidity. And looking ahead, biomarkers such as procalcitonin, MMP8 or interleukin 6 or 8 may allow bedside detection of infection within minutes. But obviously that's not something we have at present. Future hopes, shall we say. And then prompt antibiotic therapy tailored to local resistance patterns remains key to optimizing outcomes whilst maintaining good antibiotic stewardship. So having looked at the acute neutrophil-driven processes and their clinical consequences, let's now turn to the chronic inflammatory end of the spectrum for chorioamnionitis. So unlike acute chorioamnionitis, which reflects an active infectious process, chronic chorioamnionitis is typically immune-mediated, driven by maternal lymphocytic responses against fetal tissues. And this shift from infection to immune dysregulation represents a different pathophysiologic mechanism, but with equally important implications for pregnancy outcomes. So, as I mentioned, chronic chorioamnionitis is an immune-mediated process, kind of a maternal anti-fetal rejection rather than infection. So it's driven by maternal CD8 positive T cells infiltrating the chorioamniotic membranes, guided by chemokines such as CXCL9, 10 and 11, which recruit these lymphocytes to the site of inflammation. And the result is injury to the trophoblast and membrane damage, closely resembling allograft rejection. Unlike the neutrophil-rich acute form, chronic chorioamnionitis shows lymphocytic inflammation and immune dysregulation, including factors such as reduced glycodelin A, which is a molecule that helps to maintain maternal fetal tolerance. And this loss of tolerance explains why it often coexists with other chronic immune lesions, such as Villitis of unknown etiology or chronic deciduitis. Cohort data has shown that it occurs in about 10% of term and 20% of preterm deliveries, peaking between 34 and 36 weeks gestation. So that late preterm period seems to be the most susceptible period for this. Altogether, it's one of the more frequent inflammatory lesions in late preterm birth, and could play a central role in the pathway to spontaneous preterm labour. Macroscopically, there aren't any distinctive findings. This is a purely microscopic diagnosis. So in histology, we see a T-cell mediated process with lymphocytic infiltration of the chorionic trophoblast and the amnion. The inflammation usually involves the free membranes, although it can extend into the chorionic plate, especially when there are other chronic lesions present. The infiltrate, located mainly at the choriodecidual junction, tend to be patchy and limited, in contrast to the diffuse neutrophilic pattern we see in acute chorioamnionitis. Injury to the trophoblast may appear as focal necrosis or apoptosis, giving a subtle kind of moth-eaten appearance. And the degree of inflammation has been found to correlate with amniotic fluid CXCL10 levels, underscoring its immune basis. On immunohistochemistry, the infiltrate's composed mainly of CD3 and CD8 positive T cells, with few CD4 positive T cells and a rare occasional B cell. So these stains can be used to support the diagnosis when needed, though they're not typically or routinely required. Staging reflects the depth and extent of lymphocytic infiltration rather than the presence of neutrophils, consistent with its chronic immune nature. So, having considered the histology, it's important to look at the clinical significance of chronic chorioamnionitis. Though often subclinical, it reflects, as I say, a maternal T-cell mediated immune response against fetal antigens, distinct from the neutrophilic infection-driven process of acute chorioamnionitis. And this immune activation alone can trigger preterm labour or premature rupture of membranes, even without the presence of infection. Say it's one of the more frequent lesions in spontaneous preterm birth, particularly in that late preterm period, 34 to 36 weeks. And it has been linked to complications such as fetal growth restriction, low birth weight, and increased neonatal morbidity, including admission to the neonatal unit, sepsis, and perinatal mortality, especially when it's accompanied by other pathology such as pneumocystis or chorionic vasculitis. For mothers, it may suggest an underlying autoimmune predisposition and has been associated with gestational hypertension and diabetes. So diagnosis is currently entirely postnatal. However, biomarkers such as CXCL10 or glycodelin A show promise for early detection, whilst imaging tools like placental MRI or targeted ultrasound are also under investigation. Recurrence data for this remains limited, underscoring the need for longitudinal studies, but clinical awareness and postnatal confirmation remain key for now. So now I'd like to move from inflammation of the membranes, cord and chorionic plate to inflammation within the villus parenchyma itself. Acute Villitis represents infection-driven inflammation that directly involves the chorionic villi. It's a key lesion to recognise both for what it reveals about intrauterine infection, but also for its clinical impact on the fetus. So acute Villitis is a rare but severe inflammatory lesion of the placenta. It's found in less than 1% of examined placentas. It's characterised by multifocal neutrophilic infiltration of the chorionic villi, typically reflecting overwhelming fetal sepsis due to hematogenous spread of organisms, most often group B strep or E. coli. The process begins when pathogens from the maternal bloodstream reach the intervillous space, crossing or infecting the syncytiotrophoblastic barrier to then invade the villus stroma and fetal vasculature. And this direct infection provokes an intense neutrophilic inflammatory response with infiltrating cells of both maternal and fetal origin. Some viral and parasitic infections, for example, CMV, toxoplasmosis, hepatitis C or B, use specific trophoblastic receptors for entry and can also cause similar lesions. These infections may be clinically silent in the mother, but can be devastating for the fetus, leading to preterm delivery and uterine growth restriction, high drops, fetal sepsis, or stillbirth. Though uncommon, acute Villitis is a critical histopathological diagnosis, as it signals usually severe intrauterine infection and requires careful distinction from chronic immune-mediated Villitis. Grossly, acute Villitis shows no visible abnormalities unless there's accompanying acute chorioamnionitis or placental abscesses. Of note, when placental abscesses are seen, that's highly suspicious for Listeria infection, though similar lesions can occasionally occur with tuberculosis, for example. Interestingly, listerial placentas have also been described to have a distinct fruity odour. I've not smelt it myself, but that's what's described, which potentially could be a subtle but characteristic clinical clue. Microscopically, the lesion is defined by a dense neutrophilic infiltrate within the villus stroma, often extending from or coexisting with chorioamnionitis or intervillositis. The inflammation can be extensive and destructive, and in listerial cases, both micro and macro abscesses are common. On tissue, gram or silver special stains, these abscesses may reveal gram-variable organisms, confirming the infectious etiology. So, having seen the histological general pattern of acute Villitis, it's worth asking what drives this process. So, in most cases, the cause is infectious, and the organisms can often be demonstrated histologically with either on H&E alone or with special stains or by PCR, depending on the case. So two characteristic organisms within this group are group B streptococcus and Listeria. So group B strep is a gram-positive encapsulated bacterium, commonly colonizes the genital tract. It's a major cause of ascending intrauterine infection, typically following membrane rupture. Placental findings can include high-grade chorioamnionitis, funicitis, and sometimes acute Villitis, with dense neutrophilic infiltrates or microabscesses. Bacterial colonies may be visible on H&E, as seen in some fetal vessels in the image on the screen, and gram stain can be used as well. And these colonies are often found along the membranes or within the fetal vessels. There's a gram stain at the top right, and there is immunohistochemistry that often isn't used but can be done for group B strep in the image at the bottom right. So group B strep's a frequent colonizer, but also a leading cause of neonatal sepsis, producing the classic neutrophilic pattern of placental infection. Listeria monocytogenes, which is a foodborne gram-positive bacillus, has a marked tropism for the placenta. It produces necrotizing chorioamnionitis and Villitis with micro or macro abscesses, often associated with fetal sepsis. Histologically, we see neutrophilic abscesses, as seen in the image, with gram-variable bacilli on gram or silver stains. So there's a gram stain in the top right and a silver stain in the top left. Bottom right, sorry. Histologically, we see neutrophilic abscesses with these gram-variable bacilli on these gram or silver stains, and this can sometimes be confirmed by immunohistochemistry if needed. And when it comes to Listeria, this listerial pattern, as demonstrated in the H&E image on the left, of microabscesses surrounded by inflamed villi, can be a really useful diagnostic clue. So just as chorioamnionitis can be acute or chronic, Villitis also presents in two forms, or main forms. Some cases result from immune dysregulation, where the maternal immune system mounts a response against fetal tissue in the absence of infection. And this immune-mediated form, known as Villitis of unknown etiology, or VUE, is by far the most common. It's important to remember, though, that chronic Villitis can also arise from transplacental infections, such as cytomegalovirus or other pathogens. So with that distinction in mind, I'm going to have a look more closely at chronic Villitis, key histological features, mechanisms, and clinical relevance. So focusing on chronic Villitis, it's a lymphocyte predominant inflammation of the chorionic villi, most often immune-mediated, as we said, rather than infectious. And the defining feature is maternal CD8 positive T-cell infiltration of the villus stroma, which then leads to variable villus injury and fibrosis. When infection is the cause, typically with pathogens such as CMV, Toxoplasma, syphilis, the inflammation is more focal and may include viral inclusions or granulomatous change, and can be confirmed by PCR or immunostains. The most common form, VUE, represents this maternal antifetal immune reaction, showing dense T-cell and macrophage infiltration. There is evidence of reduced PD-L1 expression and an increase in chemokines such as CXCL9 and 10. Clinically, VUE is linked to complications such as growth restriction, preterm birth, stillbirth, and it has a high recurrence risk in subsequent pregnancies. A related variant, basal Villitis, affects anchoring villi and has been associated in some literature with donor oocyte pregnancies, placenta accreta spectrum, and hypertensive disorders. So, but what does it mean clinically? Whether infectious or immune-mediated, these lesions have meaningful implications for both maternal and fetal outcomes, especially when the inflammation is severe or recurrent. Villitis of unknown etiology in particular is strongly linked to fetal growth restriction, preterm birth, stillbirth, and even long-term neurodevelopmental impairment. Recurrence is common, with reported in up to 50% of subsequent pregnancies, and recurrent cases often show more severe inflammation and poorer outcomes. Maternal autoimmune or hypertensive disorders are also more frequent, again supporting this idea of immune dysregulation at the maternal-fetal interface. When chronic Villitis occurs alongside chronic histiocytic enterocolitis, the risks compound, leading to some of the most adverse placental phenotypes that we see. Given the frequency and recurrence risk and clinical importance we've just discussed, it's clear that not all Villitis behaves the same way. Some cases arise from identifiable infections, as we've said, whilst others occur entirely without pathogens. So non-infectious Villitis, you'll often hear this referred to as Villitis of unknown etiology, but as ongoing research continues to uncover its underlying immune mechanisms, it's becoming increasingly clear that it's not truly unknown anymore. However, the term remains in use. So this lesion is typically seen at or near term, as I say, characterised by this dense infiltration of maternal T cells and macrophages in the absence of infection. Pathogenetically, it represents a maternal antifetal immune response, I say essentially this breakdown in tolerance at the maternal-fetal interface, where cytotoxic T cells will target the villi, much like an allograft rejection. High-grade VUE, when it's involving more than 30% of distal villi, carries the greatest clinical relevance. Molecular studies also reinforce this immune basis. They show increased T-cell chemokines and loss of trophoblastic PD-L1 expression, again, echoing patterns seen in transplant rejection and graft versus host disease. Clinically, as I say, VUE can recur and often with greater severity in subsequent pregnancies, highlighting the importance of recognising and reporting it for future risk assessment and counselling, not just the target pregnancy itself. But so how often do we actually see it? So VUE most commonly occurs at term, affecting roughly 5 to 15% of placentas, and its frequency increases with gestational age. High grade or diffuse cases, typically in term or late term placentas, show the strongest association with fetal growth restriction, stillbirth, and neonatal morbidity. The recurrence risk can be substantial, reaching up to 50% in some literature, particularly when the lesions are severe or coexist with other inflammatory patterns. I have to say the reported rates do vary across studies, largely due to differences in case selection, population, diagnostic criteria, but the clinical importance remains consistent across them. So what does it actually look like under the microscope? So histologically, these lesions can be quite striking, especially when high grade. Instead of infection, what we see is this dense lymphohistiocytic infiltrate within the villi, giving the parenchyma kind of a characteristic bluish hue at low power, which can be a good early clue. VUE tends to have a patchy pattern with clusters of affected villi scattered among normal ones. Plasma cells can show up too, but if they're prominent, that should really raise suspicion of possible infection, particularly CMV, and prompt the use of confirmatory stains or PCR testing. We grade the lesion based on how much of the villus tissue is involved. Fewer than 10 contiguous villi for low-grade lesions, and 10 or more, or roughly 30% of the villi for high-grade or diffuse cases. Other features we often see include vascular injury, avascular villi, and perivillus fibrin. And it may also coexist with chronic chorioamnionitis or chronic deciduitis, again, reinforcing its immune-driven nature rather than infectious. Clinically, it's associated with late onset fetal growth restriction, fetal birth, stillbirth, and in surviving infants, an increased risk of neurodevelopmental issues. And I say, perhaps most importantly, it has this recurrence rate in up to half of pregnancies, and when it does recur, it's often more severe. So what does it mean for management when we've got a diagnosis of VUE and for prognosis? So the prognosis depends largely on the extent of inflammation. As I say, high-grade or diffuse cases definitely carry the greatest risk for fetal growth restriction and stillbirth. At present, there's no proven or standardised therapy, so management remains supportive, centred on close fetal monitoring and timely delivery if compromise is suspected. Some clinicians empirically use low-dose aspirin, though evidence for benefit is limited, and the real progress lies in emerging research, particularly around immune checkpoint modulation and T-cell pathway targeting. Hopefully one day may help prevent recurrence or improve outcomes. So, as we said, non-infectious Villitis, essentially an immune-mediated process, but not all chronic Villitis fits that pattern, and some cases are truly infectious where a pathogen drives the inflammation. So unlike the immune-mediated form, this type arises from direct infection of the villi, most often by cytomegalovirus, toxoplasma, or herpes virus. Histologically, it can look quite similar to immune-mediated Villitis, but the key distinction is that the infectious organism can usually be demonstrated by special stains, immunohistochemistry, or PCR testing. These infections typically spread hematogenously, with pathogens crossing from the maternal circulation into the villus trophoblast and stroma, triggering a strong innate immune response, driven by interferon and antiviral signalling pathways, something that recent molecular studies have started to help to map in greater detail. Histologically, these lesions can resemble the immune-mediated forms, but there are usually some telltale clues pointing to a specific pathogen, and that's where careful examination and confirmatory testing really come into play. So microscopically, it shows a dense infiltrate of lymphocytes and macrophages within the villostroma, similar to the non-infectious form, but often or sometimes mixed with plasma cells, which can be a clue, or neutrophils. Each pathogen can leave its own distinctive fingerprint. For example, CMV produces the classic intranuclear inclusions, while syphilis can show delicate spirochetes on silver stains. Although the inflammatory cells are largely maternal, which can make it look like VUE, the identification of this specific pathogen can confirm infection. And clinically, these infections can carry significant risks, again, such as fetal growth restriction, preterm birth, stillbirth, or subsequent congenital infection. When it comes to prognosis, the outcome depends largely on the pathogen itself and also the timing of infection. So early or severe infections tend to have the poorest outcomes, with increased risks of fetal loss, preterm delivery, or long-term neurodevelopmental effects. Unlike immune-mediated Villitis, recurrence, though, is uncommon unless the maternal infection persists. And management focuses on treating the underlying infection, for instance, penicillin for syphilis or antivirals for CMV, but there isn't any therapy that specifically targets the placental inflammation itself. Cytomegalovirus, classic example of viral Villitis, and remains the leading cause of congenital infection worldwide. It's DNA virus from the herpes family, affecting around 1% of all live births and accounting for roughly 10% of chronic Villitis cases seen. Most of the maternal infections are asymptomatic, but transplacental transmission occurs in about a third of primary infections. And clinically, it's a major cause of congenital infection, non-genetic hearing loss, and neurodevelopmental delay. Most affected infants will appear normal at birth, but around 10% are symptomatic, showing features such as growth restriction, hepatosplenomegaly, or jaundice. But even asymptomatic cases can later develop hearing loss or developmental difficulties. Macroscopically, the placenta can appear either large and edematous or small and fibrotic. And on histology, we typically see a chronic lymphocytic or plasmacytic Villitis, villus hyalinization, hyperplasia of the Hoff bile cells, and then there's characteristic cytomegalic cells with ALS I inclusions. Confirmation usually requires immunohistochemistry or in situ hybridization, and you can sometimes get hemosiderin accompanying chronic vascular injury as a non-specific clue. The prognosis is poorest when the inclusion bodies and plasmacytic Villitis are present, and overall CMV remains a major global cause of congenital infection and disability. Toxoplasmosis, another important transplacental infection, can produce its own distinct characteristic histologic findings. So it's caused by Toxoplasma gondii. It's an intracellular parasite, typically acquired from undercooked meat or food contaminated with cat feces. Maternally, the infection is usually silent, but transplacental transmission can result in congenital disease, with severity depending on whether the infection occurs during gestation. Most affected infants will appear normal at birth, but up to about 85% may later develop ocular or neurological complications, most often chorioamnionitis. The classic triad that you often hear about in the books of chorioamnionitis, hydrocephalus, and intracranial calcifications, whilst characteristic, is only rarely seen in very severe cases. On histology, often see chronic Villitis with villus fibrosis, again Hoff bile cell hyperplasia, and sometimes granulomatous inflammation. Diagnostic confirmation comes from identifying tachyzoites or bradyzoid cysts within villostroma, the amnion, or chorionic plate, and you can use special stains or immunohistochemistry again to assist. So quickly moving on, after looking at infectious causes of chronic Villitis, I want to shift gears to something quite different, a case where the inflammation isn't driven by infection at all. So this next case is a 29-year-old woman, gravida 7 para 0, with a history of recurrent pregnancy loss, including 2 in the second trimester, 3 early trimester losses. She presented with a positive home pregnancy test, and based on her LMP, gestational age was noted at 8 weeks and 3 days. However, ultrasound scan showed findings consistent with early pregnancy failure, with a crown length that corresponded to just over 6 weeks. She subsequently went on to miscarry spontaneously, and the products of conception were submitted for pathologic examination. Grossly, the specimen was composed mainly of blood clots and scant focally hemorrhagic tan pink decidua. Histologically, the products of conception showed numerous immature chorionic villi with myxoid change consistent with non-viable gestation. However, the key finding was a dense infiltrate of CD68 positive infiltrates, histiocytes, within the intervillar space, accompanied by fibrin deposition. So this is immunohistochemistry just showing the quantity and density of histiocytes. And this is the classic picture of chronic histiocytic intervillocytis, or CHI. Given her history, this lesion almost certainly underlies her recurrent pregnancy losses, a hallmark of CHI, and its association with miscarriage, severe growth restriction, and intrauterine fetal demise. Of note, none of her previous pregnancies had led to any form of placental or pathologic diagnosis, and there were no specimens sent. This was the first time that we'd received any products of conception from this lady. So looking at CHI itself more closely, it's an uncommon but clinically significant placental lesion defined by dense infiltration of maternal macrophages within the intervillar space, and often accompanied by perivillous fibrin deposition. It's best understood as an immune-mediated disorder, again a form of maternal antifetal or alloimmune rejection rather than infectious. Molecular studies have shown upregulation of interferon gamma and HLA class 2 genes consistent with a macrophage-driven alloimmune process and the breakdown of this fetal-maternal tolerance. In essence, CHI represents a placental analogue again of graft rejection, sometimes exacerbated by maternal autoimmune or inflammatory states. Histologically, CHI is striking. You'll see this dense infiltrate of mononuclear cells, mainly maternal macrophages, with some admixed lymphocytes, filling at least 5% of the intervillar space, although often it's more. Around 80% of these cells will be CD68 positive, confirming their histiocytic nature, and there's often associated perivillous and intervillous fibrin deposition, though that isn't required for the diagnosis. Occasionally, you might see chronic Villitis alongside it, but rarely. Usually, it's more of an intervillous infiltrate, and the villi themselves remain quite clean, so to speak. Clinically, this is a lesion we take very seriously. And that's because it's strongly associated with late miscarriage, stillbirth, and severe fetal growth restriction. Roughly 40 to 45% of pregnancies end in loss, and among the live births, a vast majority will have evidence of growth restriction. The outcome correlates closely with lesion severity. The denser the macrophage infiltrate, the poorer the prognosis, with survival dropping to around 16% in the most severe cases. And importantly, recurrence is really common, often with more extensive disease. And many affected patients also show autoimmune features, reinforcing again this idea that this is an immune dysregulation process rather than infectious. So whilst CHI is distinctive histologically, it's also one of the most challenging placental lesions clinically, with these high rates of loss, growth restriction, and recurrence. The real difficulty comes when we move from trying to recognise it to manage it. There's still no standardised or proven therapy, and most treatment remains empirical. Some improvement has been reported with corticosteroids, hydroxychloroquine, or low-dose aspirin, An IVIG may be helpful in recurrent or refractory cases, though the evidence is fairly limited. Given its parallels with immune rejection, though, research is increasingly focused on restoring the maternal fetal immune tolerance and modulating macrophage activity. But for now, early recognition, close fetal surveillance are key, but we clearly need better biomarkers and more targeted approaches to truly alter outcomes. So what now? Having reviewed the clinical impact outcomes associated with these lesions, it's clear that our current understanding, while substantial and improving, remains incomplete. We can now recognise the characteristic histologic patterns and their associations with adverse pregnancy outcomes, yet translating these findings into effective prevention or treatment strategies continues to be a major challenge. And this brings us an important question: where do we go from here? So I believe the next step lies in advancing our research and bridging what we see under a microscope with what happens clinically at the bedside. Future research in placental inflammation infection needs to kind of bridge our growing mechanistic understanding with this real clinical translation. A key goal, I think, could be distinguishing sterile from infectious inflammation and mapping the immune pathways that drive each. Need to clarify how maternal T cells and Hofbauer cells interact and what molecular signals trigger or sustain lesions like VUE and CUI. And these insights can help us move beyond morphology to mechanism, which is where the greatest clinical impact potentially lies. Standardization also remains essential. Consistent terminology, unified grading systems, and the incorporation of molecular diagnostics and now AI-based image tools has the potential to improve reproducibility between centres and allow meaningful comparisons across studies. Another area of growing importance is biomarker discovery. So identifying circulating or placental tissue markers could enable early or even antepartum detection of inflammation long before complications arise. At the same time, we need to continue defining the long-term consequences, not only for survival, but also for neurodevelopment, growth, and chronic disease risk in later life. Therapeutically, progress depends on rigorously designed clinical trials. Immunomodulatory and anti-inflammatory therapies such as corticosteroids or hydroxychloroquine or IVIG show promise but remain largely empirical at this point. Controlled studies will be crucial to define which interventions truly improve outcomes and to develop prevention strategies for recurrent immune lesions. And on a global level, collaboration is key. Patterns of placental inflammation differ worldwide due to variations in infection prevalence, maternal health, access to care, and international partnerships and shared databases will really help identify both universal and population-specific mechanisms, ensuring discoveries translate into equitable maternal fetal care. And then finally, continued education and cross-disciplinary dialogue are vital. The more widely that these lesions are recognised, then the better we can communicate their clinical implications, and then the more effectively pathology can be in guiding obstetric and neonatal management. So integrating placental pathology into standard perinatal assessment closes that loop between diagnosis, counselling, and prevention. So a few key takeaways. Sorry, I know I'm a few minutes over. Placental inflammation offers an extraordinary window into maternal fetal immunology, revealing both the timing and the nature of injury. Acute lesions reflect infection and its route of spread, while chronic lesions uncover breakdowns in immune tolerance at the maternal fetal interface. Accurate recognition and clear communication transform these findings from descriptive histology into clinically meaningful insights. Lesions like VUE and CHI remind us how intricate maternal immune regulation truly is and how its imbalance can profoundly affect pregnancy outcomes. So progress in this field has been a collective effort. shaped by decades of work from placental pathologists, immunologists, and obstetric teams worldwide. And their collaboration continues to deepen our understanding of this remarkable organ and its central role in pregnancy health. And ultimately, the placenta tells the story of every pregnancy. Each slide we examine offers an opportunity to inform care, prevent recurrence, and improve outcomes for mothers and infants. And ultimately, that's what it's all about. Thank you. It's just a few of my references. And yeah, I'd like to thank you all for your attention. I'm happy to take any questions or comments.
Thank you so much, Dr. Keir, for this excellent talk on placental inflammations and infections. This is wonderful. And you covered a very relevant topic for our colleagues who are practicing regularly on placental pathology. Do you mind unsharing your screen, please?
Oh, sorry. Yeah, there we go.
Yeah, thank you. There are quite a few questions and compliments from our viewers. So let me read one compliment. One of our colleagues says that thank you for making something that many pathologists are deeply concerned about more understandable.
Thank you for the comment.
And there is one question. To corroborate the diagnosis for microorganisms, and if there is the option for PCR, do you recommend performing it on paraffin-embedded tissue or on amniotic fluid when available?
So generally, that isn't kind of an option when it comes to us, because by the time that we are looking at the placenta and establishing that there's this potential chronic inflammatory or acute inflammatory process going on, the time to get amniotic fluid has passed. So usually we would just do it on FFPE. Having said that, there are occasions clinically where we will get sent amniotic fluid samples by the clinicians to look for evidence of neutrophils, say if they're concerned about an ongoing intrauterine infection. And so amniotic fluid is a really good medium for it. It's just that usually by the time it's becoming a question for myself as a pathologist, that is no longer available for us to utilise.
Right. Thank you. There is the next question is, do you always examine placenta specimens in fresh state?
So yes, not everywhere does. Some places will receive them fixed and examine them fixed, but here at Texas Children's Hospital, we examine them all fresh. So we do the macroscopic gross assessment whilst it's fresh, and then we will fix it before obviously getting our slides. I think there's pros and cons to both. Obviously not necessarily within the context of inflammation and infection, but one of the positives of receiving the placentas fresh here is that in multiple pregnancies, we're able to do sort of dye injections and test for twin-to-twin transfusion and things like that. So I know that's outside of the realms of infection and inflammation, but there are reasons like that for receiving it fresh that assist in the wider picture of placental pathology.
Right. So here is a broader question from our colleague in Mexico. I think a resident says that what would be the practical order for you to be able to study the placenta histologically? So meaning like an approach, I guess. So this is because as a resident, I still get lost trying to integrate all the findings. So maybe that's a broad question.
It is, and you could almost do a full hour-long lecture on that in itself. But ultimately, obviously, the macroscopic is your first port of call, and I would strongly signpost to the Amsterdam consensus paper, which gives a really nice breakdown on how to examine the placenta grossly, what to look at, kind of the size, the weight, how to process it, the cord, whether it's hypercoiled, hypo or hypercoiled, sort of lesions on the parenchymal cut surface. So you've got your first part is the gross assessment, and that can give you some clues, but not always. So a small placenta with focal pale lesions may get you thinking about infarcts and maternal vascular malperfusion. A big edematous may make you think infection and hydrops. Once you then get the slides, it's a case of kind of doing it stage by stage. So look at the umbilical cord, assess that, the vessels, infection, anything there. Look at the membranes. Again, you're kind of going through a stepwise process of what am I looking for, any evidence of infection, any vasculopathy, meconium, things like that. And then move on to your full thickness slides and just go through systematically, starting at the chorionic plate, the villus parenchyma, and the basal plate. And then ultimately, I think it's to practice and seeing quantity. The more placentas you look at, the easier it becomes to integrate it all. I started having to look at the chorionic plate in every single slide, and then the parenchyma in every single slide, and then the basal plate in every single slide, because I couldn't, like you, put it all together. Now I can look at it all in one go and piece it together as I go along, but that's just through a case of having done so much placental pathology reporting.
Right. Thank you. So the next question is about, let me read it for you. So do you routinely recommend microbiology cultures or PCR panels for placental tissue in certain morphologic patterns? I'm not sure if you have already touched this, but maybe you can try.
Yeah, so there isn't a one rule fits all, and that applies to placental pathology, well, pathology, I think, in general. But yes, I think if you are seeing certain factors that would trigger you to consider a certain diagnosis. So, for example, I wouldn't be ordering immunohistochemistry or PCR for viral infections on a placenta that's got acute inflammation as the key pattern. But if you're seeing those factors like plasma cells, for example, that would trigger me to do PCR. If you're seeing bacterial organisms, colonies on the H&E, then you can do a gram stain to try and further clarify what they are, gram positive, negative. So I wouldn't do it routinely. You don't always need it. But I think in any cases where there is even a hint of uncertainty, I think it can be a useful adjunct to the H&E appearance and kind of impression.
Right. I think that's good to know. So another question that I found from online is that how often do you find non-infectious mimics such as autoimmune Villitis, lupus, or maternal inflammatory response, which can masquerade as infectious process?
So that's a difficult one to answer. Good question. The placenta doesn't come with a diagnosis of a labeled diagnosis. It has patterns of disease processes. So you will often see a disease pattern that you then have to piece together with the clinical history. So clinical pathological correlation in placenta pathology is absolutely key and paramount to your ultimate diagnosis. So I haven't got a value, a percentage of how often you see mimics, so to speak, but what I can say is that you will see a pattern of inflammation, say, and then it's only really with clinical correlation that you can then sort of truly put it together in those cases that are challenging with those overlapping potential diagnoses.
Right. Thank you so much. There is another question, which is about, let me read it for you. Could you share your criteria or threshold for diagnosing chronic histiocytic intervillositis versus other macrophage-rich placentitis, macrophage-rich processes?
So for chronic histiocytic intervillositis, I say I'm looking for that predominant CD68 positive histiocytic infiltrate within the intervillar space. Now, you will often see scattered histiocytes within the intervillous space as part of the natural just background of the maternal blood supply. So I want to see it away from areas of hemorrhage, ideally. There can be a few other mixed inflammatory cells, but generally it has to be the predominant cell type. And you want to see it in at least 5%, but generally my threshold is possibly a little bit higher, based on the implications that this diagnosis potentially has. So if I'm seeing, you can sometimes get cases where you get just little microscopic foci that are suspicious for, but not diagnostic of chronic histiocytic intervillositis. So in those cases, I'll often make a comment in my report to the clinicians that I've seen this, that it doesn't reach my threshold, but I'm alerting them, because if it is, obviously we only sample such a tiny proportion of the placenta compared to the whole organ, then I want to make them aware that if there's something going not quite right in the next pregnancy, then this could be an indicator that actually there is an ongoing immune-mediated process in this patient.
Right. Thank you. One last question. Are there any emerging infectious agents or patterns you think pathologists should be particularly aware of post-COVID?
So obviously, COVID placentitis was crazy for every reason, and as people who within pathology and placental pathology are aware, it really brought to we discovered this kind of new, so to speak, diagnosis within placentas of COVID placentitis, and I think that really alerted people in the perinatal pathology world and wider to the fact that we can still get emerging and new organisms and patterns of disease. I'm not aware of any specific. I know Zika is an organism that's been sort of rumbling in the background for the past sort of, it's before COVID and still ongoing. And then the other thing is just being aware of different kind of pathogens that are common in different areas. So, for example, malaria may be far more common if you're working in a certain geographical location compared to others. So I think having an awareness of what pathogens are currently around and about it in your area is most important. For regards specific and emerging things, I'm not aware of any specifically, but I would be happy if anybody else is aware of any, please. I would love to hear about them.
Right. Thank you again. Thank you so much, Dr. Keir, for this excellent talk on placental inflammations and infectious processes, and also taking your time in sharing your knowledge and experience and interacting with our viewers. And you would be happy to hear that we had a lot of viewers, and close to 100 who joined from different parts of the world, including but not limited to Zambia. I saw someone join from Zambia, another colleague joined from Peru, someone joined from Mexico, others joined from UK, India, Brazil, and so many other places. Thanks to our viewers for supporting Pathcast, and please don't forget to follow Pathcast on our social media platforms, including Facebook, YouTube, Instagram, and X, so that you can stay updated with all the upcoming lectures and archived videos that we have. And in fact, we have close to 300 pathology lectures on so many different topics. So hope you guys are all benefiting from this. So stay tuned, and our next lecture is coming up. So we will have Dr. Laura Taves, so who would be joining us on October 21st, and she's going to give a talk which would be more like a general pathology and quite useful for the trainees. So she's going to talk on oncogenic viruses and how they are associated with cancers, and how what are the different testing methodologies. So hope to see you all at that time, and that is October 21st, same time. And thank you so much again, Dr. Keir, for your excellent presentation today. We appreciate it.
Thanks.
Thank you.